Hey everyone, welcome back to the Neurologic Wellness Podcast. I'm your host, Dr. Joe, and today I'm joined by my guest, Dr. Jonathan Arkin. Thank you for joining me today.
Hey man, thanks so much for having me. It's a pleasure to be here.
Yeah, I love having you on today. You are a wealth of knowledge, and I think our listeners are going to love what we have to talk about today. So for those of our audience who aren't familiar with you and your background, can you tell us a little bit about yourself and your specialties?
Yeah, absolutely. Been practicing for a little while now. I blend basically functional neurology, as I'm sure a lot of your audience is probably aware of the basis of that is. But essentially what we do is we take the foundations and the tenets and basically all the research out of traditional neurology, and we actually apply it into the treating of patients, which sometimes can be a little lacking in traditional neurology. So we take the knowledge and how can we make this actually work for a real life patient? And that's essentially what it is. And we see fantastic results. It's just like I'm sure the patients that you see up in your clinic, you get people who have been paralyzed for years and suddenly they're walking. You get patients who have had migraines 20 days out of the month, and then suddenly, they're having one migraine a year. So just really fantastic things. I do things a little bit different than many other practitioners because I also function. When I was in school, I kind of fell in love with traditional Chinese acupuncture. And so I started studying traditional Chinese medicine, Oriental medicine. I studied all sorts of herbs and all the acupunctural meridians and things like that. And I couldn't let it go. And then you couple that with my mentor, Dr. Mark Ellis, who, if you haven't had him on your podcast, that's the guy you got to go for because he's got some stuff to say. I tell you what.
we did have him on the podcast actually. And we talked about neurology and martial arts. If you can believe
there you go. Yeah. So he's my mentor. So pretty much everything I learned from him. I worked with him for several years. So I got very in depth. I got very into working with the fascial system, and I can't break those. So now I blend everything. And one of the things that I found, a lot of people tend to shun away. They're saying, "Oh, you're too complementary medicine," when you start saying Oriental medicine or acupuncture or any of these things. There's no problem with it though, because typically in acupuncture systems or say in Oriental medicine systems, they're generally saying the exact same thing that we're saying in traditional Western medicine. I'll give you an example. A lot of times people would scoff at, you're treating a dizzy patient and you're treating their bladder meridian, and you're going to have people will be scoffing at that. But when you open up a Oriental medicine textbook, the bladder meridian runs along basically the exact same path and feeds the same areas of the body as the vestibulospinal tract does, which is pretty cool when you think about it. So what's happening is they're actually doing a different treatment to have the same effect as what we would be doing if we were just trying to do a vestibulospinal treatment. And they're just calling it something different. So the problem with a lot of different healthcare systems that I found is they speak different languages. So one of the things that I found very, very exciting is I kind of learned to speak a different language a little bit. So sometimes my treatments might look a little bit weird, but it's always trying to fix the same stuff that you would fix in your clinic or Dr. Ellis would fix in his clinic. It just looks a little bit different because I might be using a different method to have a similar effect.
Right. And with combining traditional Chinese medicine with what people would consider, I guess, Western or research-based, whatever medicine, you have to, like you said, talk in two different languages, and you've been able to marry the two, and you're bilingual, and you're able to kind of work in both realms to give patients a better experience, it seems.
Yeah, well, and that's absolutely the goal. And it's funny you call me bilingual because I've been practicing in Norway for the last several years. And I still don't speak Norwegian. I can't do it, man. I'm bilingual in treatment, but not in real languages.
Yeah, that's a tough one to master.
You know what I mean. But yeah, so that's essentially what I do. I just blend a couple different things, and it's been very eye-opening for me because I've been very blessed with the opportunity. So I teach with the Carrick Institute, which is the preeminent postgraduate neurological education company in the entire world, and they just do some incredible stuff. If you're listening to this and you're an aspiring doctor, or you're a student, or you're a practicing doctor, you've got to check them out. Shameless plug, don't care. Yeah, so since I've been able to teach with them and hang out with that crew and like people like yourself, I've gotten very good at speaking Western medicine.
Mm-hmm.
So it's aided me in that. It's aided me in my ability to communicate with other practitioners. And so one of the very fun things, while I might do things that look or sound very weird, I have zero issue ever communicating with other healthcare practitioners. And I've never had any problems with referrals. I've never had any problems at all with arrogance in the profession at all, because you just speak to people in the language that they're comfortable hearing spoken to them. And there's no problems at all. It's very exciting. And I really encourage other people who are interested in things that maybe don't look like traditional neurology, but who still want to practice neurology. I encourage you can explore those things. Just learn what you're actually doing. And that's what one of the beautiful things about neurology. Another piece of practice that I do, which can be looked down upon sometimes, it's called applied kinesiology. And I absolutely adore applied kinesiology. I can tell you right now, well over 50% of my treatments in practice is traditional applied kinesiology treatments. And for those listeners who don't know what applied kinesiology is, it's a system of muscle testing. And they also integrate different acupuncture meridians, treatments, and there's a lot of nutrition involved in it. Well, a lot of times people would consider it as kind of like pseudoscience. And to be fair, it actually is. But that pseudoscience is simply, we do it, we have a treatment and we see what effect it has. One of the very cool things about taking a system like applied kinesiology and integrating it with neurology is that we can see what it does in traditional Western views. So we're not just saying, oh, we made an arm weak, so you're all better. No, what we're saying is that when this test improved, your nystagmus went away. So we know we effectively integrated your vestibular system better. So now your cerebrovestibular system is functioning more appropriately due to this other test. And it's very exciting because it can help you learn what not to do a lot of times. Because by studying the neurology behind someone, it can help you know what not to do in your other techniques. So whether you're a Gonsta practitioner, whether you're a masseuse, whether you're a activator practitioner, one of the things that you'll notice is that you can get great results, but sometimes you do make your patients worse. And don't tell me you don't, because you do. Every single doctor alive sometimes makes your patients worse. So what you might notice is that when you're doing, say, like the activator dance, where you're raising one arm over the head, you're checking the leg lengths, you might notice that for this patient, every time you follow the protocol, they get worse. Well, why is that? Well, neurology can actually answer that question for you. So what you do is you take, like for me, I'll take my applied kinesiology, which might look really, really weird. And my neurology will tell me, don't do what my protocol says to do. And that can really, really save you quite a bit. And I found that just to be invaluable in practice.
So,
sorry,
so sometimes you do find that those two systems do conflict with one another.
Absolutely.
And then I guess how do you build the hierarchy there between which one to pursue?
Neurology is king. Neurology is king. So, I mean, the brain and the spinal cord regulate every single function in the entire body. So if you're doing something that's going to have a negative consequence for the nervous system, you don't do it. That's just bottom line. I can tell you the only exception I can kind of understand, and I would personally never do this, but if you have a practice member or a patient and they're like, well, I don't care if you screw my brain up, my shoulder hurts, crack my shoulder. Okay, I mean, the patient's asking you to do that. Maybe then you would choose to put another hierarchy on top, but I wouldn't. I would just send them to another practice personally. But yeah, I always think you always 100% have to prioritize brain, spinal cord function, no matter what. Yeah. So it's always on top.
Yeah. And you were kind of mentioning earlier how neurology and your understanding of neurology really helped build a foundation of kind of how physiology works, right? And then once you have that strong foundation, you have your therapies and your treatments that are within the neurology scope, but then you also have this world of other therapies that have existed for thousands of years. So now that you have the foundational kind of the traditional research way of thinking about how physiology works, you can apply these modalities and treatments like Chinese medicine, like what AK uses, to be more effective. Is that correct in my thinking?
Yeah, and I'll give you a perfect example of it. Okay,
Mhm.
there's several different systems out there have pain relief techniques where they'll tap certain points on your face.
Mhm.
So if it's in traditional acupuncture, they'll call it beginning ending technique. There's a different applied kinesiology techniques. I know NET will sometimes touch different points in your head. There's lots of different systems out there, but a very, very commonality between a lot of alternative healthcare systems is that they'll tap these very specific parts on your face in order to cause a pain relief system,
Mhm.
which is weird. Why would just tapping your upper eyebrow cause, a pain relief in your shoulder?
Right.
For initially, on initial look, it doesn't make any sense. But by studying neurology, which is why everyone out there needs to study neurology or go to a practitioner who understands it, we can understand why those techniques work.
Mhm.
And sorry if I'm using slightly big words, but sometimes you just have to.
Yeah,
By
go for it.
tapping on specific regions of the face, you can activate something called your trigeminal nerve. And then your
Mhm.
trigeminal system feeds into an area of your brain called your midbrain, which has certain pain inhibitory mechanisms in it. And those pain inhibitory mechanisms do what it sounds like they do. They turn pain off.
Mhm.
So when we're doing these acupunctural techniques or these whatever, and you're tapping on this face, and it seems like it's just some random person tapping on their face, it's not random at all. It's a constant physical stimulation to activate the trigeminal system, which can help go into the midbrain and activate these pain inhibitory systems, leading to a neurological inhibition of pain. And as we study neurology, we can explain this weird stuff. And then it doesn't just become some weird thing that you're like, what the heck's that guy doing? It gives you, as the clinician, a greater knowledge of what you're doing. And it gives you a lot more tools in the belt to help your patient, if you will.
Right. Yeah, exactly. So we were talking a little bit before we started recording about, what kind of patient population you see and who's benefited the most from your care. Can we touch on that a little bit?
Yeah, absolutely. I practice in kind of like a hybrid model. So I see local patients, but I also will do intensives. So I'll have patients who fly over from Iceland, or patients who fly over from Sweden, or the north of Norway, and they'll come in and they'll stay with me for a week or 2 weeks at a time. But then I'll also be seeing local patients. So if I have a patient for a full day, for a full week treatment, I might see them for 4 hours a day. But while they're resting, I'll see local patients. I don't care.
Mhm.
I like seeing local patients, and I'll treat shoulder pain. I'll treat neck pain. I would say the majority of my practice does absolutely focus on brain injuries, migraines, and I do a decent amount of stroke rehabilitation as well.
Mhm.
Um, and it's very, very exciting because due to being able to pull from a couple different worlds of knowledge, I get to do some different things for some of these people who've been through the rat race, and they haven't been able to have relief. I'm very, very grateful for my training through Dr. Ellis, Professor Carrick, and everyone at the Carrick Institute, that I'm able to help these migraine patients and these brain injury patients, much like you yourself have helped, and all of your wonderful colleagues up there have been able to do. But it's very fun when you see some of the other stuff work as well,
Yeah.
right? And it's like, why was I able to fix this patient's nystagmus by treating their fascial system around their ear?
Mhm.
And then you get to use your neurology and you get to think all the little details of it, and it's pretty darn cool. Yeah, so we treated several patients of that like.
Mhm.
So I love treating migraines. We do very, very well with them. I love brain injuries. We do quite well with them. Strokes are always hard. Strokes are always super
Mhm.
difficult. Any benefit we get from them, it's always amazing. And sometimes we'll see miracles. Sometimes people struggle, but
Yeah.
uh, it's just kind of the way it goes when you're working with stroke rehabilitations.
Mhm.
But every day in practice is pretty amazing. You never get bored, that's for sure.
No, it always keeps you on your toes, right?
Yeah, absolutely.
I think as we're talking, people are probably developing a better and better picture about what you do. And but can you kind of walk us through maybe what an initial exam with you would look like, and
Yeah,
how you would do your neurology exam with your other traditional Chinese medicine exam?
absolutely, absolutely. So my exam is pretty darn boring. Patient comes in, I watch them walk. If I see something like, say, maybe they're not swinging their arm as much on the left, while they're walking to the table, I'll ask them to count backwards out loud. So just immediately right off the bat, I'm looking at seeing if the frontal lobe activity has an effect on their physiology. They have a sit. I do blood pressures bilaterally, so on the left and on the right, while the patient's seated, while they're laying down, while they're standing up. For those of you who don't understand why your physician might choose to do blood pressure on both sides of the body, is it okay if we take a moment and talk about that?
Sure, absolutely.
Cool, because I find this just super invaluable. So if you're a patient or if you're a student who's listening to this, it is invaluable to know what the blood pressure is doing on both sides of the body. Because most people think, and it's a false thought, but most people think that blood pressure is only controlled by your heart or by fatty cholesterol in your arteries. It's not true. Blood pressure is what it says. It's the pressure that's important. I'm not saying that cholesterol is not important. I'm not saying heart health is not important, but it's the actual pressure in the vascular system, and that is controlled neurologically. So many, many times you'll see is that a patient will have very high blood pressure on one side of the body, say the left side, but on the right side, it's actually low, or vice versa. And this can be due to either brain injury, it can be due to infection, it can be due to all sorts of things that affect the person. So I always look at blood pressure on both sides, because it can cause really dangerous issues when your physician doesn't do that, right? Because if you take, say you take your blood pressure, your doctor takes your blood pressure, and your blood pressure is something bad, like 180 over 110. And these patients exist. They're real. They show up.
Oh, yeah.
Well, we might immediately think, oh no, blood pressure medication. We have to put them on blood pressure medication. But they didn't check your blood pressure on the other side. So they actually have no idea at that point if your blood pressure is actually high because you've got fatty cholesterol deposits, or they have no idea why it's high. If your blood pressure is actually normal or low on the other side, that medication can cause drop attacks. It can cause conditions called orthostatic hypotension, where when you stand up, your blood pressure drops too much. It can cause a lot of issues. And I see this very often in patients. So I always do blood pressures, because probably the most common condition in every patient in existence, I don't care if they're there for shoulder pain, I don't care if they're there for a brain injury, every patient has what's called dysautonomia. And I know you know what dysautonomia is, but for the audience, the dysautonomia is just when you have an autonomic function. So autonomics are things like your heart rate or your breathing rate or increasing or decreasing your blood pressure. The automatic things you don't have to think about, your digestion. So we call those autonomics. A dysautonomia is when that stuff doesn't work. And the easiest way for me to figure that out is if you're dysautonomic is by taking blood pressure on both sides when you're seated, laying down, standing up. So that was a nice little tangent about blood pressures. Then we do the blood pressures. Then you'll do your traditional muscle testing for your dermatomes. Then I'll do a complete ocular exam on pretty much every patient. So saccades, which are fast eye movements, which can tell you a lot of function about someone's frontal lobe. Pursuits, which are meaning a slow eye movement. So you're following a target with your eyes. That can give a lot of information about what's called your parietal lobe, which is a patient's sense of self. So how do you know where you are in space? It can give us clues like that. And there's much more detail there, obviously. I'll always do an eye tracking. So I currently use the right eye in practice for that, to see if the patient's actually looking at what they think they're looking at. And there's a couple other goodies like that. So I do just a complete neurological examination. I check pupils. I see if they can gargle. And then after that, what I do is pretty darn simple. I get my examination. I figure out what's wrong with them. And then I try to make a change. So let's say the patient has like a problem with their alternating supination pronation on the left arm. Traditionally, we might call this a dysdiadochokinesia, but many times in practice, it's not actually a dysdiadochokinesia. It's just a bad alternating supination pronation. And if you're listening to this, basically, if you slap the palm of your hand into the palm of your other hand, and then you put the back of your hand, and you alternate that in a very rapid fashion, it should be a smooth, quick motion. For some people, it's going to be very uncoordinated, and they might even miss their hand altogether. Well, when this happens, in traditional neurology, we might think that is a problem with the cerebellum on the same side. Well, that's true. Bottom line, it's true. But the question is, how do you fix it? So I might say, if I'm thinking that I might need to do just simple like maybe I'll put red colored glasses on their eyes. And if that improves it, I know I can use light therapy in order to help the patient improve. Let's say I want to do something with the way that the patient's cranium moves to see, well, if I do a cranial motion, can I improve the cerebellum? Well, I might just gently press into the cranial system and I'll see if the alternating supination pronation test improves. If it does, I'm like, okay, cool. I'll be effective with my treatment. So for those of you who are newer starting out, or for those of you who are trying to find a clinician who you want to work with, many times if they can make an immediate difference in a test during the examination, that's a bunch of points for them probably being able to help you.
Yep.
Or if you're not certain if you can help your patient, test it out. Like if you hold this part on their back, and then suddenly when they sit up, they don't have pain, chances are pretty high that if you push that part of the back forward, you're going to help them a lot.
Right.
So it's really that simple. Any weird stuff I want to try, I'll just do it. And if it improves the neurological test, I'm like, okay, cool, that'll be successful.
And I think that is probably my favorite concept that I've taken away from at least the AK thought process is challenging, right? So if you find a positive test, maybe this is a medical test, medically neurological test that is positive, and you can do just a little thing like an eye movement or a cranial, touching the cranium in a certain way, and all of a sudden that test gets better. You can make a change in that nervous system that quickly. Like you said, that gives you a lot of confidence that you can help this patient, and you even know kind of what direction and what modality to go in. So yeah, and you are just that much more effective at treating that patient, and it's fantastic, and it's good for you, good for the patient.
Yep, I love it. So if any of you out there, I mean, just test it. If it makes anything better, it's gonna make it better when you do it for real. If it doesn't mean it won't be helpful at all. But I generally wouldn't do a month-long treatment if my test doesn't say that it's going to improve at all. I won't initiate a month-long treatment of that.
Right. And that being said, just because the challenge helps doesn't mean it's going to like solve the problem right then and there. It just shows you that that is a viable pathway to use for treating that
Which
patient.
is an issue because sometimes, yeah, and I'm really glad you bring that up, because sometimes we get overly excited when we see that we can make a change. We're like, oh, well, that's going to fix it completely.
Yep.
Doesn't work that way. It just means it might have a positive influence on the system that you're trying to affect.
Exactly. I'd say also, I've dabbled in AK a bit in that world.
You dabbled.
I have colleagues, friends who more so went down that route. But what I found really exciting whenever I get to talk with them, get to talk with you, it's how does my perspective, how can their treatments and my treatments coexist and kind of synergize with each other? So maybe we're doing like a tapping plus eye movement, or whatever else you may do in AK, and then adding in maybe some head thrusts, whatever it may be. How have you been able to, or I guess, how have you seen that affect your patients in your practice?
Well, marvelously. And it's funny because there's some strategies that I say I should always use no matter what. Like for example, there's this one technique that's very common in applied kinesiology. It's called injury recall technique, and I'm not going to get into the details of it. But it's a very simple technique that you do that can have very profound changes on patients. And it's always fascinating for me is sometimes I just don't do it, and I should, but sometimes I do. And I'll get stuck. My patient's improving. I'm seeing improvements, and then suddenly I plateau. I'm like, damn, how do I get past this plateau? Well, then I go back and I check for the systems that I know I'm supposed to check on every patient. And I'm like, crap, I didn't do that at the beginning of care. I do it. And then I suddenly just burst through the plateau and my patient can choose to improve again. Which is like, okay, well, remind me not to be an idiot. I always need to stick to things that I know will treat my patients. And it's really easy to find out when you're in practice what those things are. Because what you do is you try them and you see neurologically if it has an effect. And if it has an effect, it's going to have an effect when you actually do it for treatment.
Right. And I would say, oh, just gonna pause. And kind of piggybacking off of one of our previous conversation, we we know that we can make a pretty immediate change with just challenges, right? Do you also find that you're going to know if you're going to be successful with a patient pretty early on based on your therapies, as far as treatment? You might know after a few treatments if you're going to be successful or not, because this stuff does tend to work quickly.
Within a certain percentage, right? I mean,
Mhm.
if I'm working for you for a week and there's zero, if I say, take one of my intensive patients, for example,
Mhm.
say I have a patient and they fly in and they want to stay with me for 2 weeks and they're a traumatic brain injury. They haven't been able to work for 10 years.
Mhm.
They can't really stand up right now because they've got a horrible condition where if they stand up, their blood pressure drops. Well, I know that if I've been treating them for 4 days and there's no improvement, chances are low I'm going to be effective on them,
Right.
right? And on the flip side, right? Say I've been treating them for 4 days and they're 80% better. Well, probably going to be pretty darn effective on them.
Of
But
course.
it's never conclusive, right? I mean, you
Mhm.
can get massive results on a person very quickly, and
Mhm.
those can end up being the most frustrating patients that you've ever had because you never completely fix them.
Mhm.
And you can have some of those patients who it's like maybe they're getting 1% better, 3% better here, but it's like their life really isn't changed. Sometimes those are the patients who they just need more care.
Mhm.
And it can be very frustrating when you're not accurate in your estimation. But typically speaking, I would say that absolutely, if you're seeing a 50% improvement in your first 2 weeks working with a patient, chances are super high you're going to be very, very successful with them. So that's one thing that I like to do in my practice is taking my local patients. I never actually tell someone how long their care plan is after my exam because
Mhm.
I have no idea at that point,
Yeah.
right?
Exactly.
I can tell if I think I'm going to be effective based off of whether I've been able to improve certain examination findings or not.
Mhm.
But any number I give then is kind of guessing.
Right.
So what I always do is just depending on the condition, I put them on a trial, and say we're on a month trial and I'm seeing you twice a week. Well, at the end of week 2, if your shoulder pain is down by 25% and you have increased range of motion by a bunch, I can go ahead and then give you an accurate estimation of how long I think our care is going to be. I'm like, hey, listen, you're a lot better. Chances are really high. You're going to be done in a month.
Yep.
And then if I'm done in 3 weeks, wonderful.
Mhm.
You always try to overestimate when you're communicating with patients. Um, and if you're a patient listening to this really applies to you as well. So if you're with a physician who is taking the time to explain things to you and they're giving you a logical explanation for what they think is wrong with you, and you've been with them for 2 weeks and you're improving, chances are pretty high that person's gonna get you at least 80% better.
Yeah. You're probably
If
in the right
you're with
place.
them for 3 months and there's no improvement,
Mhm.
it doesn't mean that they're a bad physician or that they're not doing what's best for you,
Mhm.
but chances are probably pretty low that you're going to get results. And at that time, it might be a good time to sit down with your physician and speak to them about, well, how can we change this? Because the answer very well could be, well, listen, Mrs. Jones, your saccadic latency has decreased. Your blood pressure control is dramatically improved. I know you're not feeling better, but all of your objective symptoms are improving, and we just need a little bit more time. And
Mhm.
that's a reasonable answer sometimes. But if your clinician can't give you a reasonable answer that's logical, it might be time to move on and try to find someone else.
Mhm. Yeah, exactly. And I'm glad you brought up objective findings too, because we hang our hats pretty heavily in the funk neuro world on objective
Mhm.
findings. A lot of
Absolutely.
times, it's very hard to explain what we're seeing and why it's significant.
Hmm.
But I think one of the beautiful things with AK is, you know, there's a very simple and effective visual for a patient if they see like their arm is strong and then immediately the arm goes weak if they do something that provokes their symptoms or something else. So I think that's great.
Yeah, it's massively. It's a very, very good tool. So for those of you who don't know what Dr. Couples is talking about here, what we're saying is in applied kinesiology, we will test certain muscle function for whether it is stable or unstable. And there's a grading scale to provide like how stable versus how unstable it is. But sometimes you'll have a patient who, if you do what's called a deltoid test, so just imagine you're like doing a bicep curl, but have your arm at like a middle bend and then raise it up at the side. So it's shooting out straight to the side. If you push down on that arm with maybe almost no strength and the patient can't hold it and it hurts, and then we say turn your head to the right and then suddenly there's no pain and your shoulder is super stable, that's pretty good to show you that, yeah, we're going to be able to fix the shoulder problem, right?
Yeah.
It works quite well. So that's what we were kind of discussing just then.
Mm-hmm. Yeah, and it's always, I think, interesting. You'll get, probably you see this more than I do, if you have a big athlete and you are able to muscle test them, and they think like, this guy's not going to overpower me. He's $130, and but
you get the bodybuilder out there and you use your pinky to throw.
Yeah, and then you just make him go weak just like nothing. And but yeah.
Now, could I bring up one other thing about the muscle test that I think is really important for people to hear?
Yeah, absolutely.
Now, this is actually very, very exciting. So if you're a student or you're a doctor and then you've probably seen people muscle test, and you are in your head trying to figure out, well, what the heck is happening there? They're probably just pushing too hard. Well, I went to talk to Professor Carrick about this. And for those of you who don't know who Professor Carrick is, he's the father of functional neurology. He's one of the most preeminent physicians in history, and he's just incredible. And he's got a student who is doing their doctoral study on this, and they wrote a long paper on what's actually happening in the muscle test. And he had just mentioned it offhand at one of his seminars. So I went up to him, I asked him, I was like, hey, I'd love to read this paper. And he goes, great, I'll send it to you. So he sent it to me in Italian. And it was very kind of him. It was pretty funny though.
Yeah.
So we got it translated, and I read the paper. And the muscle test, for those of you who aren't familiar with it, just imagine this. You're holding your arm straight out in front of you, and a clinician presses down on it, not as hard as they can, but they press down on it with a certain amount of pressure, and they slowly increase their pressure. What they're looking for is for you to be able to increase your resistance so that your arm doesn't move it. It's not an arm wrestling test, so they're never pushing as hard as they can. It's just to see, can you meet the same amount of pressure they're pushing into your arm by pushing it up? And if you can't, then the muscle doesn't function correctly. All right. Well, in the study that Professor Carrick's student, and I apologize, I don't remember the doctor's name, who wrote the paper. What he found, and this is just a neuro nerd alert here, people. So sorry if I go into it, but if you're a geek, you're gonna love this. What happens when during an applied kinesiology muscle test, when we apply a certain amount of pressure to the limb, and the limb fails to increase to meet the pressure of the examiner, so the limb is functionally weak, as we say, what we notice is that there's no change in the excitability of the spinocerebellar tract or the rubrospinal tract, or not the spine, sorry, this corticospinal tract or the rubrospinal tract. And what's really fascinating about this is the corticospinal and the rubrospinal tract are heavily responsible for voluntary motion. Mm-hmm. So by using a forced, I'm going to sound very ignorant here, but I forgot the name of the force dynamometer. It's a tool that measures how hard you're pushing into the person's arm. Forgive me for my ignorance here. And we'll call it the force dynameter for argument's sake. And we know that the clinician isn't pushing harder. And we know that they're not overpowering the patient. And by analyzing the excitability of the corticospinal tract and the rubrospinal tract, we know that the patient is not trying less. Mm-hmm. So the patient is putting forth the same amount of intensity and attempt to meet the clinician's pressure, and the clinician is using the same amount of pressure, but the arm is weak or the leg is weak. Yeah. How can that happen? The only way that can happen is through reflexive mechanisms. So there is in the applied kinesiology test, when someone's arm is strong and then suddenly it turns weak, it is not the clinician overpowering you. And if it is, that's a bad clinician. And it is not the patient giving up. What's happening is we are getting reflexogenic systems causing what's called autogenic inhibition of the muscle.
Mhm.
And that should excite everyone, because that is, take it to the bank, real. There's a lot about applied kinesiology we don't know. Don't get me wrong, but that is very real. The muscle test is actually completely reflexive, and it is not voluntary at all, which is very cool.
Yep. Is there a muscle group that you prefer to use that you feel like gives you a more accurate representation?
Yeah, I use extensors significantly more often than flexors. And then for anyone who's listening to this with a neurological background, you probably understand why. But for those of you who don't, the reason why is because extension, and that just means like bringing your arm back or pushing your fingers up versus curling your fingers. So anything that's like curling inwards would be called flexion. Anything that's like bringing your body backwards is extension, more or less. Extension is it's a little bit tricky because we don't actually extend our body. So when you stand up and you fight gravity, you're not actually extending and fighting gravity. What you're doing is you are inhibiting flexion, meaning you're turning off the fetal position, and you're turning on standing upright. But the only reason you stand upright is because you are effectively turning off the fetal position. So I always try to use more extensors due to the fact that it's more sensitive to higher brain function. And I find it's generally more sensitive test. Now, is that real? No one knows. Clinically, is it real? It's very real clinically, right?
Exactly. And then you're able to use this muscle test to gain information on the patient. And like we talked about earlier, just to kind of wrap it up, or just to summarize, you're able to gain information on that patient from the muscle test, which allows you to not only show that patient some objective markers on how their body is functioning, but it also gives you as a clinician the ability to be more effective in your treatments based on the patient's own response to the stimuli you introduce to them.
Absolutely. And it really, really helps you out. If you as a clinician have some things that you know always works, but it doesn't work when you test it on this person, don't waste your time doing it. It's not going to work on that person. Move on.
Yep, exactly.
It gives you tons. It helps so much.
So, Dr. Arkin, we are just about out of time for the podcast. But I wanted to make sure we budgeted enough time for you to, leave us with any final remarks that we may not have touched on just yet.
Yeah, absolutely. I think we just talked about a lot, and I'm very sorry because I'm going to miss you that you have to go so soon. This has been lovely getting to hang out.
It has been great.
But if you're a patient, one of the things that I would give you as the best advice for when you're finding your doctor is, and sometimes we're afraid to say this, but I'm not afraid to make waves, so I'm going to say it. One of the most important things for you is your doctor needs to be able to explain what's going on to you in a logical manner. You don't have to understand all the fancy words. That's not important. But they need to be able to explain to you what's happening to you logically. Or they need to be very honest with you when they say, I don't know what's wrong with you, but I know I can improve your symptoms still. Either one is actually a pretty dang good answer. If your physician cannot explain to you logically, or they can't admit that they don't know what's wrong, but at least they know they can help your symptoms, it's not the physician for you. I can pretty much guarantee you that. And if you're a student and you're looking to get into a world, neurology is going to give you the whether you want to just do adjustments to people's necks, if you only want to adjust C1, if you only want to say do left big toe adjustments, it doesn't matter. Do whatever you want to practice. Do the way that makes you happy. But learning neurology is going to help you know what not to do on patients. Even if that's it, even if that's the only thing you learn, what you'll notice is that you're not going to be that doctor who helps 80% of their patients and makes 20% of them worse. You might be that doctor. You might be that doctor who helps 80% of your patients and makes no one worse, but you might be ineffective on 20. But I can guarantee you that if you can help that if you get those 20% and you're ineffective with them, you're going to be infinitely happier with your practice volume, with your own work, than you will if those 20% aren't just ineffective, but they actually get worse. And that happens to people all the time. You see people in these chiropractic clinics or these physical therapy clinics or these medical clinics. It happens everywhere. All these doctors are helping a lot of people, but they're also hurting some people. And if we can decrease the amount of patients that we're hurting just by studying a little bit, then you damn well better do that. And that's where neurology, I find, is unbelievably useful for every therapist, not just chiropractic people, therapists in the world, medical, physical therapist, masseuse, whatever. You have to learn neurology. Not everyone has to be like a complete expert in it, but you have to learn it because it will bare minimum tell you what not to do on your patient.
I'm glad you brought that up because sometimes the best clinicians are the best because of what they don't do, not because of what they do. So that's very important. Dr. Arkin, thank you very much for your wisdom today. If our listeners and viewers wanted to find out more about you and your practice, how would they go about doing that?
So we're actually, thanks for asking. So we're actually in the process of moving. So we are leaving Norway right now, and we are moving to South Carolina in the United States. We're going to be located in Lexington, South Carolina, which is right outside of Columbia, which is the capital of South Carolina, for those of you who don't know. We're building out as we speak. Hopefully, we'll be able to open by Q4 this year. The name of the clinic will be Carolina Chiropractic Neurology Clinic. So you'll be able to find us on our website, which is currently under construction right now. And hopefully, if anyone has questions, you're always welcome to contact me at drjonathanarkin@gmail.com. And I appreciate your time, Dr. Joe. This was great.
Well, Norway's loss, South Carolina's gain. So.
Well, I got my woman. I went over there and I channeled my inner Viking, and I stole my woman. I married her, and now I'm bringing her back to my country to display my conquest. For all of those, everyone who just listened to that, I'm clearly joking. I went over and I cried and I begged her to marry me, and then she allowed me to join her family. Okay, so don't say it. That was
really a sweet story. Yeah, and maybe that's actually what happened back in history too. I just wanted to sound intimidating.
You want to sound pretty good, right? But realistically, we know who's busted.
Exactly. Well, thank you again, Dr. Arkin, for sitting down with us today. This has been great, and I think our listeners are going to get a lot out of this. So thank you again.
All right, thanks, Doc.
Yep. And then from your host, this has been the Neuro Wellness Podcast. Be well.